Welcome everybody. I'm David Sandman. I'm the president of the foundation. We're happy to have you all with us here today for this conversation about New York's surprise bill law, which of course we at the foundation do view as a major accomplishment for the state and entirely consistent with the foundation's newest priority area, which is focused on consumer empowerment and healthcare. So it was sort of good timing. It was 2 days ago that I saw on PBS. They aired their own story about this issue, which some of you may have seen. And they told this story of this guy named Andrew Heyman. And Andrew was helping his friend move, I guess, from one apartment to another. And in doing so, the friend's glass coffee table shattered. And Andrew sliced open his ankle really bad on the broken glass. Ambulance was called. He got rushed to the hospital. He was 100% certain this hospital was in his insurance network. And so you can imagine he was more than surprised, not in a good way, when he ended up getting a $6,000 bill from a plastic surgeon who apparently, who did treat him, but apparently was not in his network. And Andrew was lucky. Andrew somehow got his employer to cover most of that bill for him, and so made it out okay, and his ankle's fine, I should say. And PBS, they sort of covered this story with this sort of like tone of discovery, like they had just found that this was a big issue and was worthy of PBS. But we know, everyone in this room knows, these kinds of stories are not uncommon. Consumer Reports put out their own work that showed these stories are all too common. And it's obviously a case where New York State, is way ahead of the curve by having enacted our surprise bill law that many people have called the toughest law in the nation. And that was, the result of efforts by so many stakeholders, many of you in the room or representing those stakeholders. It was the state, it was consumer advocates, it was the health plans themselves, it was provider associations. There were a lot of forces that ultimately came together to get this done. The format of these is always meant to be informal. That's not a good slide, but that's the only slide you're going to see. There's no PowerPoint, nothing. We asked for that. Our speakers today are well known to many of you, but Mark Scherzer is an attorney in private practice, a very long time consumer advocate. He served as legislative counsel to New Yorkers for Accessible Health Coverage and is currently the co-chair of the Policy Committee of Healthcare for All in New York. And the bios that I was sent, they included lots and lots of interesting little things, so I picked out one for each. And Mark was awarded the Lambda Legal Defense Liberty Award, and that was as long ago as 1992 for his groundbreaking work on behalf of people with HIV and AIDS. So you can see that Mark's been in the forefront of this for a long, long time, and it has not really let up. Troy Oeschner, also a good friend to many of us, is Superintendent for Health at DFS. We're so glad you're back in that job, Troy. Welcome back. Where he is responsible for regulation of all commercial health insurance in the state. Before joining DFS, he was the Deputy Chief of the Attorney General's Healthcare Bureau. And Troy's fun fact is better than Mark's. Troy's bio says that he coaches his son's soccer team and he plays in a Zydeco band. So, you decide. But I wasn't going to ignore that. Anyway, Mark's going to kick us off today. He's going to describe, what he thought the problems were and why he and others thought that new legislation was needed. I'm going to hand it to Troy, who's going to kind of walk us through the key parts of the law, which really has many provisions to it. And maybe more importantly, share with us some of the early results. The law has now been in effect for about a year, so how's it working? What do we know? We'll circle back to Mark to get his reactions. I've got some questions of my own that I'd love to hear the answers to, and we've reserved a lot of time for all of you. A lot of audience discussion and Q&A, so get ready, because your time is coming. All right, so Mark, it's all yours. Thanks.
Okay, well, I want to echo thank you. It's great to see many of you who some of you I haven't seen in a very long time. And I want to echo what David said, that this law really does represent the efforts of all the stakeholders who managed to get through some very sticky issues and come together, because I think everyone The health plans, the providers, and the consumers realized we had a pretty dysfunctional system of dealing with out-of-network reimbursement and people who got services from out-of-network providers. And it's called the surprise bill law because, of course, a central aspect of it does have to do with people who are surprised to find that they have an obligation to pay for something when they thought they were getting in-network services. I asked Elizabeth and her folks at CSS to generate some of the cases they had been dealing with recently under the law with some substantial degree of success, and they involve the classic examples. The person who was referred by his primary care physician to an orthopedist for surgery, he didn't realize the orthopedist wasn't in network, he ended up with a $20,000 bill. The woman who had an in-network surgery by an in-network surgeon, but didn't realize the anesthesiologist, who was arranged for not by her, was going to be out of network. The person whose doctor sent blood lab tests off to an out-of-network lab. All of these situations were where people didn't really have control over whether they were in network or out of network or knowledge enough to make the decision. But this was a long time coming, and David suggested I sort of look back a little bit, so I took the opportunity to look back at where the advocacy, from at least our perspective, came from over the course of the years. And I went back, I thought I should go back maybe roughly 8 to 10 years to see, because that seemed a relevant period. And I looked at the NYFAC, New Yorkers for Accessible Health Coverage, issues in 2008 and where we were focused then. And we had, we had a persistent level of complaint, which I think was the real focus of everybody's out-of-network concerns if you go back 10 years. And it didn't have to do so much with surprise. I mean, there were hearings actually held by the Department of Health and the Department of Insurance, as it was then called, in 2008 about surprise bills. But the real focus was on how insurers were computing what they paid to people. It wasn't, it was all about whether when the insurer told you the bill was for the usual, customary, and reasonable amount, was it really? Or was it based on some captive database that was used by the insurance company, through a company it owned to create the data, in which people got underpaid because they were somehow skewing the data. You may recall that the then Attorney General went after the plans, entered into settlements, and those settlements included not only payment, but payment that was used to set up a nonprofit organization, Fair Health, which created an impartial database for computing usual, customary, and reasonable charges. And a lot of people saw this as a very big step toward resolving a problem, and it turned out it didn't. Okay. The other item on our legislative agenda in 2008 around out-of-network coverage was trying to expand the rules that applied in HMOs to say if you didn't have an adequate in-network specialist for your needs, you could go out-of-network. We wanted to expand that across the market to EPOs and PPOs and whatever, because there was no such protection there for that. That was the extent of our legislative agenda, or our agenda around out-of-network coverage in 2008. Well, what happens in 2009? Fair Health is set up, and it's resolved everything, except it hasn't, because a lot of insurers stopped using usual, customary, and reasonable as the basis for determining what they were going to pay anyway. You know, those of us on the other side may have imputed bad motives to this. I'm sure it's mixed motives. It was saving money and whatever, but many went over to a Medicare fee-based way of reimbursing for out-of-network care, so that the UCR issue became, in many ways, much less relevant. And we were seeing more and more network plans, network-based plans, in which there was no out-of-network option. The availability of out-of-network coverage in general was diminishing, although people still had a lot of encounters with out-of-network providers, which we, of course, are still facing. So by 2010, our legislative agenda had shifted. We kept our initial issues around expanding the rights to out-of-network specialists, but we also started demanding network adequacy requirements for all plans, EPOs, PPOs, et cetera, not just for HMOs, which were subject to the health department's regulation. And we started talking about trying to make sure that there were some options available where people could get reimbursed based on usual, customary, and reasonable, because when they were based on a percentage of Medicare, it was coming nowhere close to what they were expecting to get. Meanwhile, the insurance department was busy examining their huge base of complaints. I think there were 10,000 between 2008 and 2012. And they issued a report in 2012, and I'm going to leave it to Troy to describe the contents of that report, but I will give you my summary of what I think that report did. It gave us a paradigm shift. Instead of talking about the substantive right to go out of network, to get to, I mean, those are still very important, were very important to us, remained important to us, but the focus based on the complaints they were getting became much more on the issue of, I guess you'd call procedural due process or something to that effect. I mean, did the person have a real opportunity to know whether they were getting an out-of-network service? Did they know what it was going to cost? Were they making any decision about getting the out-of-network treatment? And when they were making the decision, were they making it based on adequate information? And whose responsibility was it to get them that information? That was a whole, I think, different way of framing the issue, and an extremely productive one. So that by 2013, when I looked at our legislative agenda, we had adopted, and I think Healthcare for All New York was very much in the same position as the consumer groups, we had adopted all of those elements of issues around in consumer empowerment, consumer knowledge, information to the consumer, that became ultimately part of the bill. One of the people, and David gave an example of one person, and I keep coming back to my favorite client, Claudia Knafo. And you've all probably heard her story, but to me, it really exemplified all these issues of the many different streams of the flow of information problem. Claudia Knafo was a concert pianist. She needed back surgery. She wasn't able to play because it was affecting her fingers. And she went and interviewed surgeons who she understood to be in-network only. She based it in part on the hospital saying, we have these doctors here, and they are in these networks. So she based it on a list of a doctor who was in the network. She goes to see the doctor. She says, I have this Oxford policy. Doctor said, no problem. That wasn't very much information. But she went ahead and had the surgery with this doctor. It turned out a few months later, she gets a check from Oxford, a carrier, for $66,000. And she calls and says, what's this? And they said, oh, well, it's an out-of-network service, so we pay you, and you pay the doctor, and you sign the check over the doctor. She had great consternation about this, but she followed instructions, she checked with the doctor, she did it. Now the doctor, it turns out, she saw in the explanation of benefits form, had actually billed $100,000, $97,000. And so she had this extra bill for 30-some-odd thousand to the doctor, which she was very concerned about. And the doctor said, oh, don't worry about it, just do an appeal to the plan, because they should pay more, they're underpaying. She did the appeal, because she was told by the doctor this is less than what's usual, customary, and reasonable. And the result of the appeal was an adverse decision, a really adverse decision, because the health plan said, we didn't realize this when we first processed your claim, but in fact, we no longer base our reimbursement on usual, customary, and reasonable. We base our reimbursement on this percentage of Medicare, and we should have paid you $3,400. So we now pursue you, and she started getting collection letters from the plan for $60-some-odd thousand. So she's getting pursued by the plan for $60,000 that she's given to the doctor, and she's being pursued by the doctor's bill collectors for $30-something thousand. This was not a comfortable situation to be in. But it kind of exemplified the entire breakdown of information to the consumer that the consumer could use, because she didn't know that the doctor wasn't in network, she didn't know how much he would charge, she didn't know how much the plan would pay, the plan didn't know how much it would pay. And these are all elements of the surprise bill law that I think were very effectively addressed. So I will turn it now to Troy to address exactly what the study showed and what the surprise bill law did for Claudia. Well, and we'll come back to it, not for Claudia, but for many people like Claudia.
Thanks, Mark. And before I talk about the report, I want to say thank you to David and the rest of the foundation for having this. And it's kind of funny when you were mentioning like PBS made this great discovery that there's this problem out there that those of us who've been working on this for a long time recognize the problem and that it's long standing. When I first came to to meet Ben Losky, who was the old superintendent, my old boss, he said, "So what's like the biggest problem going on with healthcare consumers right now?" And I said, without skipping a beat, surprise bills from out-of-network providers. And it was right before we were going to the National Association of Insurance Commissioners. It was his first meeting there, and he had just started, and so he went there, and we were at the health committee meeting, and he said, has anybody else heard about this problem of balance billing? Like the whole room cracked up because of course everybody had heard it, but what we heard back was there isn't really a good solution. It falls in between the cracks. There's no really good legal framework to pin it on either the insurers or the providers, and the consumers end up getting stuck. So one of the first things we did was to put out a report, Unwelcome Surprise, and there were a lot of people that helped advise us on the report. And the one thing I have to say is if you're ever going to get involved in this, I was just fortunate to have the most amazing team backing me up. Lizette Johnson, Emily Donovan, who are here today, were just unbelievable. in making this report happen and making the bill happen. But it was really an effort, as other people have alluded to, by the entire healthcare community. Of course, the consumer advocates first and foremost in front, but health plans were really concerned about this issue and really wanted it resolved. They were dealing with huge bills from particularly the emergency rooms in HMOs, where they were stuck with the bill. They had to hold the consumer harmless, but they were seeing really high charges. Providers also were a huge part of making this happen. The hospitals certainly were concerned, and Kathy and the hospital associations were great allies, because it was their patients who were often really unhappy with it. And of course the physicians, the medical society was a huge ally in trying to figure out how we grapple with this in a fair way, and certainly concerned about some of the trends that they saw going on with out-of-network reimbursement and the ability of their physicians to remain out-of-network. So we did this report, and we did a whole big data call on the insurers. We looked at our own complaints, and we found a number of things consistent with what Mark said. One of I'd say the most crucial thing we found was that indeed consumers were being billed regularly large amounts from out-of-network doctors, and they had done everything they reasonably could have to stay in network. And that sort of, as Mark framed it, due process, that was sort of the core of the bill, the piece that was driving both the report and our solution, which was in the legislation, which was when the consumer hasn't done anything wrong, they've done everything they reasonably could to comply with all the rules of the plan, to stay in network, and they nonetheless get a bill from an out-of-network provider, they should be fully insulated from liability. And so that's I'd say the most important core piece of the bill. So for any emergency condition now, whether it's in a par or non-par hospital, the consumer's held harmless, is taken out of liability for it. And for any surprise bill, we talk about what a surprise bill is, but surprise bill is either where the consumer didn't have any knowledge, or where there wasn't, and the consumer didn't have a choice. There wasn't an in-network provider available to them. That's a surprise bill, and they're taken out of liability for that. And we've now made the dispute between the health plan and the physician. And one of the biggest difficulties in this bill, probably the thing we spent the most time negotiating over with all the parties, was how do you resolve that dispute? And so we created a dispute resolution mechanism, the IDR, Independent Dispute Resolution Mechanism. Went through many iterations, a lot of difficult negotiations around it, but what we ended up with was that there were a few principles that were really core to making the IDR work. Number one is it had to be timely. It had to coincide with the prompt pay rules, because we didn't want providers not being paid for their services outside the prompt pay rules. So the dispute resolution had to happen quick, within the 30-day window, consistent with the prompt pay law. And we needed to make it not a long arbitration process. That was a huge concern of the doctors in particular. So we did this process where the independent reviewer chooses either the provider's bill or the insurer's offer of payment. So it's one of those two. The idea being it's quick, you don't have to do a lot of, it's either one or the other, and it would hopefully compel both the doctors to bill reasonably and the insurers to pay reasonably, so that we wouldn't have to use the IDR too much at the end of the day. The factors that the IDR has to consider included, it's a wide range of things, but whether there's a gross disparity between the provider's charge and what other out-of-network providers are charging, and the provider's training experience, the particular characteristics of that patient and the surgery or procedure that's happening, and they must consider UCR, which we talked about, using fair health. So those were all important things that they have to consider. I'll talk about how the IDR dispute resolution process has been working at the end, but that was the core of the bill, taking the consumers out of it and the alternative dispute resolution mechanism. Second area that we talked about in the report that made it into the bill that Mark has mentioned was network adequacy protections. So one of the things that we felt was really important to consumers, it's always better for consumers if the provider is in network. And we wanted to make a sound vote for networks, because they are always better for the consumer. The cost sharing is better. If you have a good, robust network, that's always going to be better for the consumer than having to be forced to go out of network. So one of the things that we did in the bill was to give the Department of Financial Services the same ability to be able to look at all health insurance for network adequacy, commercial health insurance, not just what the prior law was, which gave the Department of Health the authority to look at HMOs only, which is only about 15% of the commercial market. So we wanted to be able to look at the other 85%, check in the first instance to make sure that the networks were adequate and robust. The second piece, and Mark had mentioned this, that we found there were instances where the consumer didn't have a viable option to go in network, and so the new rule was, and this was a rule that already existed for HMOs, if the insurer did not have an appropriate provider in network, the consumer could go out of network for the in-network cost sharing amount. And if there was a dispute about that, in other words, the consumer thought, or the treating physician thought, yeah, the in-network provider is not appropriate, but the health plan disagreed, there's an external appeal to that so that you have an independent physician reviewing that decision. So that was another problem that we identified in the report that we resolved in the statute. A third area that we looked at was disclosure. As Mark had mentioned, we had a lot of concern. Feel free to jump in on anything. We had a lot of instances where there just clearly wasn't adequate disclosure, and we saw this in a number of different areas that we talked about in the report, and that we certainly heard about from a number of different stakeholders. One was when consumers were shopping for coverage. And I remember speaking at some chambers of commerce about healthcare issues, and I had folks come up to me, small business, and say, hey, my out-of-network coverage actually got better. It went from 80% to 140%. What they didn't realize was that it was going from 80% of the usual customary rate, UCR, which is fairly robust, to 140% of Medicare, which was a much lesser amount. Now, to be fair to the insurers, they were getting a lot of pressure from employers to not pay such generous amounts out of network because it was really expensive to do that. So they were, in a lot of instances, the insurers were reacting to market pressure. But in the first instance, consumers didn't really have a good sense when they were shopping for coverage what they were really buying in terms of out-of-network coverage. So one of the things the law did was make sure that put requirements on the health plan to disclose their methodology very clearly for how they're calculating out-of-network services, how that methodology compares to the usual customary rate, and examples of various out-of-pocket costs and how those compare what the health plan would pay to what UCR would be, the usual customary rate using Fair Health. So that was one way we dealt with disclosure around shopping, but then now you've shopped as a consumer, you've purchased coverage, and you want to use it. How do we improve the disclosure to try and reduce the instances of surprise billing? So on the health plans, we are now requiring under the law to make health plans disclose which providers are reasonably anticipated to be providing out-of-network services when they're doing a scheduled service, a pre-authorization. Also on pre-auth, the approximate dollar that the plan's going to cover, and how to find out the reasonably anticipated out-of-pocket costs based on UCR 80th percentile of Fair Health. So those are some of the disclosures for health plans. We also work with the hospitals on coming up with some disclosures for hospitals, the list of standard charges, the participating plans that the hospital participates with, the physician groups that the hospital is contracted with, and whether, when they're doing registration or admissions material, whether the services of the physicians who are employed by the hospital or contracted by the hospital are likely to be provided, and how the consumer could determine whether those physicians participate in their health plan. For doctors, the disclosure included whether the doctor participates in the health plan. They have to disclose that the charges for the reasonably anticipated procedure is available, and if the consumer asks for those charges, they have to provide them. And if the doctor is scheduling the service in the hospital, they have to disclose which doctors they've asked to be part of that procedure in advance. So that's a little bit about the disclosure. One of the fourth area that we dealt with in the report that we saw as a problem and we dealt with in the legislation was, and Mark mentioned this, was the availability of a rich benefit. And so one of the things that the statute requires is that for group plans, there has to be, and I know it doesn't deal with individuals,
This
we
is
can
where I
talk
will
about
chime
this.
in.
Yeah, and feel free, if you want to chime in now, go ahead.
I can't emphasize enough, it's only for group plans.
Right.
We used to have, until 2014, a mandate in the state that individuals be able to buy coverage that included out-of-network coverage, would give them the freedom to choose to go out-of-network and get some reimbursement. We have not seen fit to do so since, and we therefore only have individual out-of-network coverage available in a few far western counties around Buffalo, I believe.
Yes.
Not down here.
Right, not downstate, that is true.
That's
So,
continuing thorn in our side.
Understood, we can talk about that more, as part of the discussion, and I'm happy to hear other people's views on that. So the make available requirement for the, UCR benefit in the group, but not in the individual context. And the last big piece of the statute that we noticed was that there wasn't a electronic claim submission capability for consumers on out-of-network claims, and so that relatively minor, but important for a number of consumers to be able to do that. That was kind of the last piece. So that's high-level overview of kind of some of the basic provisions, and what I will say is that, Mark had mentioned this, but I've done now 2 presentations to the National Associations of Insurance Commissioners, done a few webinars hosted by Consumers Union. I know Chuck Bell isn't here, but Chuck's been a great advocate for this. In fact, they put out this really amazing advocates guide. You can get it online as well for people around the country. And so we had many states, many advocates. I have worked individually as well as our team with numerous states around the country using our bill as the model, and it's really caught on. In terms of how it's working 1 year in, so far, we'll see how things go, but so far it seems to be a success. Our helplines are reporting that definitely a hugely reduced incidence of any serious complaints on it. When we look at the dispute resolution process, as of about 2 months ago, or a month and a half ago, we had 341 dispute resolutions around emergency room services, and a little over half the decisions went in favor of the health plan, but a lot of them were split decisions, and in other words, where there may have been multiple different procedures that were being appealed or disputed all at once, and so some went for the provider, some went for the health plan, and in a lot of instances, settlements were reached ultimately, which is a really good thing, and it appears that providers did fairly well on some of the settlement provisions. But it's not unlike external appeal generally, where it's a mix. It's about half the time the insurers are prevailing and half the time the providers are prevailing, and so that probably means that it's working reasonably well. But there's a lot of really knowledgeable people here, and I'm interested to hear if anybody else has some experiences with it, either working or not working in any dramatic fashions. Yeah.
So just to follow up on what Troy said, how is it doing? I also have had similar experience to Troy. I get a lot of inquiries from people who think it's a real useful model to work on. I addressed this group of high-level insurance executives in Washington a couple Octobers ago, right after the bill passed. Somebody in the group had characterized this as New York having been captive to the consumer groups. And then, but then when I described the actual content of the bill, they sort of did a poll in the room, and there was pretty broad consensus that it was a really reasonable way to deal with the problem, and it was not seen so much as a captive thing. But I think there are some gaps we can identify. When they put out the regs and I was reading them, I was really shocked. I thought, gee, something is wrong here. But in order for it to be, it didn't occur to me at the time we were negotiating the language of this bill, and maybe smarter people could have done better at this. But to be a surprise bill, you have to be it has to be either a situation where you need a referral to get to that doctor, so you've been referred by your plan doctor, or it's a procedure you got in an in-network facility, like an ambulatory care center or hospital, from an out-of-network doctor. And I realized Claudia Knafo, our poster child, is not covered by this law. She would not have had this. I mean, she certainly got misinformation. Her hospital didn't have an up-to-date roster of what the doctors were participating in. Her doctor misled her about what plans he was in. But she didn't need a referral. She had a point of service plan. So she went shopping for doctors based on that, and because she had that kind of coverage, she wouldn't be covered by the law. Now, Elizabeth pointed out to me yesterday that the most common problem that CSS is encountering is a very similar one based on the same definitional problem of what is a surprise bill. Health plan tells someone to go to a primary care physician. They go to the primary care physician thinking it's an in-network thing because the health plan told them that that was a network doctor. And lo and behold, it's not a network doctor. But they didn't need a referral to go to a primary care physician. It wasn't a procedure that was done in an in-network facility. These people are not covered and there's no remedy for them. And I get quite a fair number of calls. I had an email last week from somebody inquiring, a resident of Alabama, covered by her employer coverage there. She was in Oceanside, New York, and had to have surgery here. Out-of-network bills, not covered by her network. Can she do anything? I mean, she's been told there's this surprise bill thing in New York. But we don't cover out-of-state plans. Even if you happen to be a New York resident and you go to New York providers, if you happen to work in New Jersey and have coverage through your New Jersey health plan, that plan is not bound to our alternative dispute resolution mechanism. Those people are basically excluded from protection. I think New York could legally take a broader view of its jurisdiction. People are providing information to New York residents which is inaccurate about their coverage. Maybe we have some sort of long-arm jurisdiction to take them into our tentacles, but those are not covered plans. Self-insured plans, obviously, we can't regulate here in New York, but also people who are in like Medicare Advantage plans are not covered by our legislation also, right? So there's significant gaps in who is covered by this. Troy mentioned the 300 and some emergency service alternative dispute resolutions. On the surprise bill side, outside of the emergency context, there have been very, very few that have actually been processed. I think through February, the information I had was that 3 had been determined. Now, this is not necessarily a sign that the system is not working. It may be that it's working very well because people submit their assignment of benefit forms to the insurer and the doctor. The insurer and the doctor work it out, and nobody feels the need to initiate the alternative dispute resolution. The consumer may, get an explanation of benefit form, but even if you, CSS, I don't know if you can even track what happens to a lot of these things where you tell the consumer to do this, they do it, they may never come back because the problem's resolved.
Yeah, that happens a lot.
So the system, may be working very well, but I don't think we have studied it in such a way that we know for sure. And I don't know if there's been any situations. We have another provision of the law where people who have no insurance at all, whose doctor doesn't tell them what it's going to cost, can dispute with the doctor through the system. I don't think there have been any disputes processed under that provision.
I don't believe so.
But again, if there's a situation where we don't know really whether the consumer is getting the information, whether consumers know they have this available to them, if there is a dispute, I think this is, those parts of the law may be very hard to evaluate unless some money institution wants to put resources into studying them.
Okay, well, great, thanks. So let me ask you a few questions to get things rolling and then get the audience in. So, Troy, my first question is actually for you. I want a little bit of the behind-the-scenes sausage making, but not about getting the law passed, because there's always a lot of negotiation accordingly. I'm really more like post-enacting the law. We move to the implementation phase. What were the hard parts, the big sticking points in actually implementing this? And then how did all the various stakeholders come together to work through those?
I think one of there were a couple of issues around when we were writing the regs. One of them, and Lizette, Emily, jump in here, please. But one of them was what could be considered in an independent dispute resolution process. And so the way it was phrased, we pretty closely followed the statute, and all the different things that I had mentioned needed to be considered, including UCR, and then we put any other information that either party wanted to submit. We weren't going to preclude, because there could be lots of different relevant things, and we'd leave it to the independent dispute person. I think there were some in the provider side who did not want to allow insurers to submit evidence of other reimbursement rates and what those would be like, and we left it open to that. So that was certainly one point of contention. What else was a big point of contention?
I don't know. We resolved everything, and ultimately, it's regulation.
I have one. What has to be paid by the plan in an emergency situation? So we know that the plan has to hold the patient harmless.
Correct.
But that was a situation where we had a state law requiring hold harmless, and we had a federal law that established a minimum. And it's really no conclusion as to what has to be paid, and so there's a lot of back and forth on that right now.
Well, are you saying in terms of whether the ultimate payment needs to go directly to the
No,
provider?
that's a different issue.
That's yet another issue.
That's yet another.
But just
On the physician side, you have the dispute resolution process, but it's a little bit less clear on the hospital side.
Right.
In those situations.
correct. Yep. Yep.
Mark, you actually kind of anticipated my next question, which is, how will we know in a robust, holistic way how well this is working? I mean, Troy, you offered up like, well, people are complaining less, so that seems good.
That's a good
We
gauge.
have the data that we have about when actual dispute resolution gets triggered, but you kind of alluded to, but there's a lot of stuff maybe going on that we don't know about, which could be good or bad. So,
Right.
What other kind of monitoring or tracking could be put in place?
If somebody has a thought there that might be
I
better.
mean, so I provide legal services to cancer patients, so one of the response would be like, you can ask. I've been working with cancer patients for about 4 or 5 years. Surprise bills are a way of life. The patients are getting surgeries, are getting chemotherapy, radiation, clinical trials, and I've definitely seen a decrease in the bill being sent to the patient. Sometimes we'll do the forms that we send directly to the provider, the out-of-network reimbursements, but what I've noticed is that the hospital is catching it, the providers are catching it, or the insurance company is catching it. So although again, like you said, you're getting 3, I think it does seem, adequate to be working
Yeah,
in that regard.
I think, and having the resources to ask the patient is, if you have an organization that has the resources to do that, and you can put that information out, that would be valuable to the world at large. I think there are other, situations where, it may be harder to follow up unless we can actually fund some follow-upping. I mean, our organizations will get complaints, and I think the perception is a lot fewer complaints on these issues are coming in general.
Troy, is there something else that
Although,
TFS
I
wishes
just-
you knew?
Is there something I think having some more visibility, I mean, we're not omniscient by any stretch, we've got limited resources, so knowing in what instances consumers maybe aren't aware of their rights, aren't exercising their rights, and what maybe some of the impediments might be, because we have a lot of instances where an IDR request was received, but then it wasn't acted on. So getting more information about why is that? Is it because it got resolved, or is it because there's some impediment that we don't know about? Because obviously.
Well, that's kind of my next question, actually. So what kind of consumer education or outreach was done? Like, if someone finds themselves in this situation, how would they know that these protections exist for them?
Well, we talked a lot about that, and I think, at least from my perspective, we really partnered with the health plans on figuring that out. And, obviously it's in their consumer contract and handbook, and there's that information that goes out there, but nobody's really focused on that, let's be honest, until they've got a bill. That's when their attention is really focused. So the key thing that we worked on was language in the EOBs that go out to the patient that give them knowledge about this right. And so we work collaboratively with the insurers on coming up with that language that, we're always up for tinkering with it and improving on it, but to us, that was the most important thing, because when the consumer gets that piece of paper, hey, there's a bill here, the service, that's when you need the knowledge about your rights the most.
Yeah, and I'm not sure it's even being effective there. I mean, that's one thing I can sort of gauge from experience a little bit. I get calls all the time from people who find my website because they think they need a health insurance lawyer, right? And I mentioned Community Health Advocates, which is supposed to, if you think you need help with this bill, go to Community Health Advocates. It's like I mentioned the name, they say, well, what's that? It's like they're still not really getting the message that they're, that they know somehow they've heard something about surprise bill, but they think they need a lawyer to deal with it, and they don't necessarily. And maybe there's a more effective way of conveying that information to the consumer.
Well, let's just open it up. I mean, I have so many questions, but there's a lot of smart people here, so questions, comments, the floor is open. Elizabeth, do you want to start?
It's not that big of a deal.
Why don't you
except
tell
that I would
everybody
say-
who you are?
My name's Elizabeth Benjamin, and I work at Community Health Advocates, which is a project of the Community Services Society. We're the state independent consumer assistance program under the Section 1002 of the Affordable Care Act. And Aaron Webb, Nakia Outly, Flo Ramirez are all here from CHA. We have a live answer helpline, as well as a network of community-based organizations and chambers of commerce throughout the state that help people with their insurance problems. On the helpline, we have actually seen a lot of calls because people think they're covered by this law. They've heard about the law, and they're not actually covered. The people that are told by their plan that a doctor is in network or a facility is in network, and it's not, really as sort of the leading, I think we've identified that as the leading sort of area where people sort of mistakenly think they're covered under the law, and then they end up with a bill, and that's been a hardship for our clients. And I just want to say that we're still getting a ton of calls, unlike DFS in that area, but Luzette may want to weigh in on
No, and I,
Yeah.
certainly that's a problem, and I think what the law did to try and prevent that is it imposed requirements that ensures that they have to update their provider directories within 15 days of the change. It also imposed requirements on providers where they have to list on their websites and disclose to patients the health plans in which they're participating. And I can also tell you this is something that we're checking first when we're looking at the networks for adequacy. We sample and we call the directories to verify. We're also checking it on market conduct and finding plans when they are not in
I mean,
compliance.
I think that would be a really interesting topic for one of these at some point, is just talking about the network assessment process that New York does, where we want to go, what we are able to do, if, the surveillance, is there enforcement action happening in this area or not? How is this all sort of organized between Department of Health and Department of Financial Services, because it sort of lives in a couple of different places, and God forbid you're talking about the basic health plan, who no one is claiming and everyone's claiming, depending on if we're talking about its revenue. It's really, I think there's a whole, which is, and not, it's not that there aren't amazing people working on this in all these, in the various forms of government, but I feel like because there's a couple of different agencies, including New York State Health, it does feel like some of the network stuff kind of gets, I don't know what the right expression, but sort of, it's kind of everywhere and nowhere all at once. It sometimes feels like, is that fair to say? I don't know.
I'm sorry. Let's respond, and then we'll go to the back. I saw a hand. Did you want to respond?
Yeah, no, as Elizabeth knows, I agree. We agree that one of the next big areas that we need to really expand our horizons on and develop better is network adequacy and how we're dealing with that. Number one, the standards that are being used, and really taking a good look at those to make sure that we've got reasonable but solid network adequacy standards in the first place. Secondly, that there's really good transparency. There's a lot of areas that consumers don't fully understand what it is they're buying. They don't understand the narrow networks. They can't comparison shop effectively. And then third, our enforcement. How are we, working collaboratively with different stakeholders and the insurers to try and make sure that mistakes aren't made and that things are portrayed accurately.
Please, in the back.
I would say that one of the things that we've seen.
Tell folks who you are.
Oh, I'm sorry, Maggie Mori with Aetna. Something that we've seen that may inform some of what you're hearing, and who knew. I guess doctors have multiple taxpayer identification numbers. So the same doctor, and some of this is coming probably out of billing administrators. I'm not suggesting anything nefarious, but there's business practices that are going on where the doctor in that same building right over there could very well be in network, but the billing administrator is billing out as a non-par, and we're seeing that. Nobody would know that. That really is a surprise bill. You don't know that until you get it, and so and we don't know it either.
My team's groaning in agreement.
So it's something that calls for, the network may be robust, it may be adequate, but we have no idea until the bill, and nor does the member, until the bill gets in their hand, what has been billed under. So I think that that's certainly an area that in the transparency and in the disclosure space needs to be a lot clearer just up front.
And Maggie, just a question. I mean, we've been talking about whether the consumer groups, say for example, or the sisters might have a way of tracking these problems. But it would seem you guys might be also a very good resource if you have ways of keeping track of people who are calling and saying, I thought this doctor was in network, why aren't you?
That's the only reason that we know. I mean, we certainly don't have a list of all the taxpayer identification numbers that a provider would use. But it's when somebody calls and you go back to the tape where they advised this, and then you actually have to kind of match it up against what was actually billed under. And
Yeah, I'm just wondering if there's some sort of systematic way that the health plans could be tracking this as an issue, not just the ID numbers, but the general, mistaken network identification.
The challenge I would see with us as the source for that, Mark, is that you don't know until you don't know.
Right.
In fact, we were dealing with an issue recently, coming out of Long Island, where if you were to actually pull the in-network doctor's, taxpayer identification, he had like 5 claims, so we were trending something, and until we had gotten the surprise bill question from the member, we had no idea. When we pulled that identification, we had actually processed a lot of out-of-network claims with that doctor, but really had no idea because you weren't marrying up what was going on. So you wouldn't know, you don't know until
Right.
you trip into things. I don't know how that's tracked. I'm not even sure, what the business practice would be, but there are lots of reasons why I would suspect it, but from an affordability point of view, I would think from a consumer group point of view down the road, you can deal with the surprise bill, but sooner or later, the push there is gonna end up in either the network getting narrower or the rate needing to expand to kind of balance those things out. So from what we're seeing, yes, we're seeing those kinds of things working, but we're seeing lips that raise other questions that we haven't necessarily figured out yet. How do you get to the right answer on that?
Thanks. Please.
Sure, so I'm Sarah Rothstein, I'm with the 32BJ Health Fund. We have 200,000 covered lives, the majority of whom are in New York State. We have always protected members from involuntary bills from out-of-network providers, and we'll negotiate with the provider and pay whatever it is, so members never pay more than what they would have paid had it been in-network. It means that we as a health fund wind up paying an awful lot of money to providers, and I think the two things that we are still regularly seeing is when ancillary providers work with the primary surgeon. So for example, the anesthesiologist, pathology, who are working with the gastroenterologist on a routine colonoscopy. One of the things that we have talked to our TPA about is why that's allowed, since they have a contract with their providers that said to be in our network, you can only work with in-network providers. And our TPA has explained the very liberal process that they have with providers to cut them out of the network if they refuse to use other in-network providers. We don't have enough political power with that TPA to get them to change their internal policies and practices. But I think it would be worth a broader conversation with the other sort of funds and payers, I'm guessing are not super represented in this room, to figure out how we sort of bring action with the TPAs, because that's a lot of business in the state. The other thing we're seeing is for emergency services, where the majority of physicians at a facility are gonna be in network, but because someone needed brain surgery, spinal surgery, abdominal surgery at 3 in the morning on a Saturday, they wind up bringing someone in who's not in network. It is particularly problematic at some hospitals more than others. And so I'd be interested in terms of what people are thinking about how to smooth that out. I think we're not looking to require insurers to contract with an enrolling provider, but at the same time feel like hospitals have an obligation to provide covered services if they're licensed to provide services. Because we routinely, week after week, see bills of $70,000, $120,000, $250,000 for involuntary emergency services. The Medicare rate for those might be $1,300. But Fair Health is going to be something close to the charges that the physician is asking for. We're trying to think if there's certain circumstances where we should start sending those claims through the IDR process, and are sort of trying to figure out, what the right best case is to test that with. But those are some of the things.
Why wouldn't you have already been doing that?
Internal politics, we have to get trustee approval to do that. Yeah. And I think that the question is, if we could negotiate for 80% of charges, are we better off doing it than sending it to the IDR, which might tell us we might have to pay 100% of charges? Don't know.
Yeah. Well, we can talk offline, but, certainly you would think, my initial reaction, and, maybe some of our health plan friends who do TPA work could weigh in as well, but you'd think there'd be some interest in the TPA in providing that value to be a little bit tougher in that sense, because you're their client. And so, there's like Northeast Business Group on Health, there's a number of places you could probably go to try and have that conversation. in terms of, if I understood it correctly, saying like, after hours going, where people go to a hospital on a weekend and there's just out-of-network coverage and not in-network coverage. I know that some of the early discussions around how to handle this were, well, just make the hospitals have, if they participate, everyone that, in there who provides services at the hospital should also participate with the same plans. And I've had a number of folks at hospitals sort of explain to me in vivid detail why that's just, as a practical matter, not gonna work in this world. And, Kathy, I don't know if you wanna chime in on that, but,
Well, it's, and in most cases, this situation, they're not hospital employees, they're.
Speak up, please.
Sorry, this situation really deals mostly with physicians that aren't employed by the hospital.
Yep.
And to get them to take call on the weekends at 3 o'clock
No, I
in the morning.
understand there's
Yeah,
very
so,
real
yeah.
market dynamics,
Yeah.
nonetheless, they suck for us.
yeah, they do.
Yep.
Yeah.
Mark, and I'll come back to that.
Two things. One to Troy, I think,
Tell everyone who you are.
Mark Hanna with Metro New York Healthcare for All. I think, and this may be sort of what Mark, you were alluding to, simply having something on an EOB about your rights may not be enough to sort of be informative to consumers, and it's also sort of kind of after the fact. And I'm wondering if there are some consumer-facing materials that DFS could put out that maybe all insurers would be required to send to their members, a simple brochure pamphlet. Here's how to plan to avoid surprise bills, and here's what to do if you get them. In kind of the broad strokes, and then where you can get additional help, and of course refer to your member plan book for, the minute details that you may need to be aware of, because I don't think a lot of mainly consumers have any clue. They know this law is out there, but that's probably about all they know about it. The other thing is, in terms of my own experience in using the healthcare system, this whole thing is so balkanized in terms of the networks, in terms of you've got a primary care provider, you've got a surgeon, an anesthesiologist, a pathologist, a lab, and they supposedly are all connected to this one institution, but they're not all sort of playing by the same rules in terms of in-network, out-of-network. And then it becomes this enormous burden on the consumer to try to keep track of that and sort all of that out, particularly when they may be moving parts over time constantly. So I just wonder if there's some way to kind of that the department can think about in terms of, de-balkanizing this process as we're moving to provider networks. The providers that are connected to some institution, they're all in that network. No matter what kind of provider they're in, it would make it so much easier. I know that.
Agree. I agree that would make it a lot easier, and
probably for the
open
payers, too.
to thoughts on how to do that, and an interesting idea on the consumer notice piece. I think you wanted to say.
Okay, you've got your hand
Can
up.
I just,
but-
Okay.
I just wanted to
Did you wanna
mention
respond?
about.
well, I was just gonna, go ahead, then I can respond.
Okay,
All right.
about the consumer issue,
Yeah.
consumer information. We can't solve all the problems, but for those of you who have an immediate interest, if you go to our website, there is consumer-oriented material,
Yes.
bilingual, about surprise bills, about a lot of other topics. In fact, there's shortly going to be a 101, we call it Health Insurance 101. There's soon going to be a short article explaining what rights immigrants, both legal and undocumented, have to healthcare and health insurance in this country. So, but there is a lot of information about surprise bills, about dealing with insurance companies, and it's, for consumers, it's free, so you can download it.
Yeah, and I was just gonna add too, to Mark's point, DFS, we have a lot of information on our website for consumers about surprise bills. We also require health plans to post this information on their websites. But, I think your brochure is a really interesting idea, and that's, definitely something we should talk about.
Yeah, I think it's something worth, maybe we could discuss with our health plan partners about, the feasibility. Yeah, you make a legitimate point. It's great to to find out about the information after the fact, but is there some information that could be provided maybe on a pre-auth approval or something like that directly to the consumer? Because that's another point where they're going to be focused on what.
Heidi was just whispering, you may want to think about doing something jointly with the AG's office, so everybody's kind of like the same.
What do you say, Carol?
Maggie, did you want to?
Well, I was gonna go to a slightly different place, but to that, I will say that, every one of the carriers has not just are required to have cost estimator tools, and I certainly know in both physical tools in terms of paper, which I don't think a lot of members actually look at, to be
No,
honest with you,
right.
but there's lots of different places where what I call the red alerts come up. You know, you will save money by going in network, or this will not be covered. I think the hard thing, and having been a consumer as well, is as the Balkanized is a good example, you often don't know who's seeing you. In the PBS special, David, that was quite the news hour, since we were one of the ones that was referenced, and largely that was, it's a very good example, Mark, of what you were talking about. Not the guy with the glass, but the guy who had the heart surgery. He was with a New York employer. His surgery was in New Jersey. It has more generous out-of-network and different kinds of rules and different consumer rights. But the doctor that saw him was I think an interventionist who dropped in for 3 days, making sure before the surgery, because he was admitted on a Friday night and the surgery was Monday. That was the only part of his $200,000 stay that was a surprise bill out of network. With that said, nobody knew about it until he actually talked to PBS. But it's a good example of how complicated it gets. I was going to suggest that an area that I think, and it's been alluded to here, that would value some idea of what's working and what's not, is really taking a look at some of the specialties, particularly in the ER, and looking at the Fair Health database of billed charges from 2013, 14, 15, 16. So to kind of test whether or not that responsibility that you spoke to, Troy, in terms of responsible payments and responsible billing practices, how that relates, frankly, to medical inflation and how that's going to relate ultimately to cost. Because I think some of what we're seeing would echo some of what 32BJ is seeing, and I hope we're not your TPA.
You're not.
But I will say that we have seen certain specialties which have dramatically increased their bill charges. We've also seen other specialties go directly to a Fair Health 80 bill charge. They weren't there before,
Right,
but they
but
are
they're
now
at 80 or
all
higher.
in the ER because they know that that's where the arbitrator is going to come down. So in other words, what's happened is there's an inherent, it's already increased the cost without anything happening. But when and it's showing up much more in the ER space. And one additional element that I've been seeing in the ER, that we've been seeing, and I don't have an answer for this either, is how the ER service is being characterized. The length of time now seems to have changed. So if you had to see the plastic surgeon to get sewn up, the ER may do the initial stitching, and then they tell you, to go to the person the next day to make sure that it was set properly and all those other. That's coming under the auspices of the ER because doesn't need to be a surprise bill because they can go in essentially, and kind of build Fair Health 80 charge on it because ER has a set of consumer protections, right? So it's just interesting dynamics that ultimately are going to show up, and somehow you're going to have to pay for it.
Yep.
So you gave me a chance for a plug. You mentioned the plan's cost estimator tools. So the foundation has been supporting Consumers Union. Some of those tools are a lot better than others. Consumers Union has been assessing those that are in New York State, mostly looking at those who have a good one, what's so good about it? What are the best practices in these estimator tools? So keep your eyes open for that. So thanks for creating that opportunity for me. This is a New York event, so you need a chance to brag a little bit. So I want to hear about who's copying us, right? Florida was sort of inspired and enacted a law that's resembles ours to a great extent. Tell us about, everyone across the country who's been asking you about this.
I don't know the exact current status of everybody, but I've worked extensively with Pennsylvania, with Rhode Island, with California, Oregon, Washington, a little bit with Maryland, Florida, talked to Texas.
That's a lot.
Yeah, there's probably some I'm missing, but most of them were through NEI, the National Association of Insurance Commissioners. I did the 2 different presentations and had people come up to me, and then we did follow-up calls with staff.
So let me bring this full circle. That last question, you said that when Ben arrived and he said, what's the biggest issue? And you said, it's surprise bills. So we have a newly confirmed superintendent, and when she comes to you and says, Troy, what's next? What's the biggest issue for consumer protection that we need to deal with? What's it going to be?
I would say next on our agenda, big time. I mean, there's a whole series of issues, but one of the big ones
They all want to know, so.
is what I mentioned, which is network adequacy, and making sure that our criteria are really solid, that the transparency is improved, and that we've improved our enforcement capabilities. But there's a number of other issues as well.
So this whole thing started, I ran into Troy on the street. He was coming out of a prep downtown, and I said, oh, I just saw this little thing in Cranes, we should do an event. And so here we are. So that's how big things get started. So thanks to both of you for being here. We really appreciate it. Thank you.